So I'd like to thank the LSRS for allowing us to present our work, and also my co-authors for their contribution towards this work. Here are my disclosures. L4-5 degenerative spondylolisthesis is a typical pathology for the spine surgeon to address. And it can be addressed in numerous ways, but the lateral lumbar interbody fusion provides a really elegant approach to interbody stabilization when it's got a proven track record, and versus traditional open procedures, a significant reduction in blood loss, morbidity, thus improved time to walking and improved hospital stay. But with all these improvements in outcomes, it's still estimated that only 20% adoption exists for the lateral approach. And this is typically because spine surgeons are trained on the posterior approach. It has an ease of positioning, the ability to access the posterior column for decompression and to perform osteotomies, and also it avoids having to flip the patient. Some workarounds exist to avoid flipping. These include stage in the anterior and posterior procedure, or unilateral fixation in the lateral position. But there's an increased emphasis on single position surgery. And so a work group was put together to try to brainstorm the ideas behind achieving the benefits of the lateral approach, all while in the prone position. This was improved efficiency, not a substantial selling point to the patient per se, but efficiency regarding time and also resource utilization. And thus the purpose of today's talk is to present the feasibility and the initial multi-center clinical experience of performing the lateral interbody fusion in the prone position. So our methods, simulations were initially conducted in serious cadavers, and then after the refinement of the initial technique, the clinical experience followed. Here you can see the patient positioned in the prone position, ready for the prone transpsoas approach. There are bolsters placed on the contralateral side in order to avoid pistoning of the spine, because the work has changed from an up-down vertical trajectory to a side-to-side horizontal trajectory. The incision is translated more posterior, so the midpoint of the incision is centered over the posterior vertebral body wall, the foramen itself. And this is because there's a gravitational pull driving things ventrally. Retroperitoneal access is similar to the decubitus position, with sweeping away the anterior contents, palpation of the quadratus lumborum, transverse process, psoas, and then sequential dilation. Vertebral body screws were considered initially in order to anchor the retractor to the spine itself, but these have fallen out of favor. There's two main ways in which to conduct the disc work: either sitting down on a chair or standing with the table planed away from you in order to improve line of sight. Here you can see an example of trying to achieve the orthogonal position while rotating the table away to optimize line of sight. While rotating the table away, it's important to rotate the C-arm equally in order to keep true to the orthogonal position when doing the disc work. Visualization in the prone position is adequate. 17 spine surgeons contributed cases. This cohort included 57 patients and 82 operative levels, most of which were inclusive of L4-5. Time to docking and mean retraction time was similar to the decubitus position, 14 minutes and 23 minutes, respectively. Many cases were supplemented with posterior pedicle screws, and what's interesting is that there's an ability to both work on the posterior column, where one person is placing screws, and then in the anterior column, one person is actually doing the disc work. into body stabilization. Blood loss is similar to the decubitus position. And of complications, 2 segmental bleeders, both of which were controlled from placement of the vertebral body screws. What's important is no cases of great vessel or permanent neurological injury were seen during this study. What's also interesting is that 3 cases of the prone approach were converted to TLIF without flipping the patient. So this study describes the initial multi-center clinical experience. The prone lateral is not only feasible, but it creates a tremendous amount of efficiencies when considering single position surgery. Here you can see some case examples on the top of 1 level, or at the bottom, a 2-level stabilization, lateral interbody technique, all in the prone position. This is a case of a patient with adjacent segment issues at L3-4 and a lumbar flat back. Hypolordotic implant was placed all without releasing formally the ALL. And so placing the patient in the prone position can allow for optimal alignment with the hips and the knees extended. And this can work in a favorable way when considering restoration of lumbar lordosis. Thank you for your attention.